Welcome to the first of two Step 1 primer videos on upper extremity nerves. This video will focus on the brachial plexus and brachial plexus injuries. We hope you enjoy it.
Let's go over the three-question warm-up for Neuro 19. First question, which gram-positive organism matches each of the following statements? So an infant with poor muscle tone, that's going to be Clostridium botulinum, and botulinum toxin. Diarrhea after using antibiotics, think about Clostridium difficile. Respiratory distress in a postal worker, what we're going for here is Bacillus anthracis. Right after 9/11, there was this huge concern that there was going to be inhalation anthrax spread through the postal service as an agent of biological warfare. Then otitis media in children, it's most commonly strep pneumo if it's bacterial at all. Now, lots of time, otitis media is a viral infection. And then cellulitis is most commonly going to be Staph aureus and strep pyogenes, or group A strep. Next, what's the classic presenting symptom in a patient with Lyme disease? So classic presenting symptom is erythema chronica migrans, which is expanding bullseye rash with central clearing. And the last one, what's the function of macrophages in the spleen? So macrophages in the spleen remove encapsulated bacteria, and they remove dysfunctional cells like dysfunctional red cells. Now let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on the brachial plexus and the upper extremity nerves. Students, you've been studying for a long time. In fact, you're closing in on your first 100 videos. Woohoo! Now by this time you're in one of three groups. The first group consists of students, though fatigued, are focused and are kicking it into the next gear to keep the learning going. Group 2 consists of students on the brink of a freakout. Their brain is at capacity, they're not feeling too good, so no sudden movement around these guys. Just back away slowly, don't say any high yield things or they'll pop. Then the third group are the ones that have already given up and are now watching these videos as a part of a drinking game. Anytime I say moving on, they take a drink. I'm told I say that a lot, so moving on. So today we're going to cover the brachial plexus and the upper extremity nerves. And before we talk about all this stuff, we need to talk about the anatomy of the neck because it's actually pretty important for Step 1. Now it's always hard to teach anatomy because most of the time we have to say, hey, look at that picture. You should probably remember what's on that picture. So you may need to actually break out your anatomy book again, brush away some of the cobwebs. So our strategy is not to waste your time by showing you every anatomy picture that we can find and tell you, hey, that's important to remember that. Instead, we're going to try to hit the highest yield anatomy and then cover the pathology associated with that anatomy. Okay, so let's move on to the neck. So first, one way to organize the neck is to separate it into two different triangular regions, which are separated by the sternocleidomastoid muscle. So the first thing you need to do is locate the sternocleidomastoid muscle. Very important there. So that's separating the posterior triangle from the anterior triangle. Well, what forms the posterior triangle? Well, it's the sternocleidomastoid that we just talked about, the trapezius muscle, and the clavicle. So remember, the sternocleidomastoid, the trapezius, and the clavicle. So now one thing that you need to know is what's in the posterior triangle. So some very important stuff. Well, you have the brachial plexus, which is very pertinent to our lecture today. And then also near the clavicle, specifically at the mid-clavicle, you have the subclavian vein, another very important anatomical feature there. Also, in the posterior triangle, you have the external jugular vein. And then a muscle that's present in the posterior triangle, very important here, is overlying the posterior triangle, is the inferior portion of the omohyoid. So those are all the important things you need to remember in the posterior triangle. Now let's move on to the other side of the sternocleidomastoid and talk about the anterior triangle of the neck. A little bit more anatomy here. So the anterior triangle is formed by the midline of the neck, or the trachea, the mandible on the superior aspect, and then on the lateral aspect, again, we have our sternocleidomastoid. So what do we have in this region? Well, up in the superior aspect, you have the posterior digastric muscle. Closer to the midline of the neck, you have the sternothyroid muscle. Lateral to that, you have your sternohyoid muscle. And then lateral to that, your superior omohyoid muscle. And then as that muscle goes down inferiorly, that goes into the posterior triangle, and then it becomes the inferior omohyoid that we talked about before. All right, so remember some of that anatomy there. That's probably about as in detail as we're going to get in regards to each individual muscle. All right, so now let's move on to the brachial plexus, and we know that this is in the posterior triangle. So the brachial plexus is a network of nerve fibers that originate from the spine and then ultimately result in those named nerves that we know that supply sensation and muscle innervation to the upper extremity. So now we're actually going to have to label the brachial plexus. This is a 4-star topic. Most of you are going to have a question on this. So this is also in the study guide, and I want you to actually write down the answers here, and we'll probably have to go through this a couple different times before you get it. So the brachial plexus comes from C5, C6, C7, C8, and T1. So those are the nerve roots. And then the roots become your trunks, which then become your divisions, and then your cords, and then your terminal branches. So there's a lot of crisscrossing, a lot of combining here. So there's a few different mnemonics that you can use to help to remember this. Some that have been used in the past. One that we like is called Randy Travis Drinks Coors Beer, and that goes for roots to trunks to divisions to cords to branches or terminal branches. But whatever works for you. So let's look at these. So again, we're labeling our brachial plexus. So look here at letter A. That's kind of the one outlier here that's a little bit different. It seems like it's coming up way high up, but it's actually producing a more distal nerve here. So this is the long thoracic nerve. So the long thoracic nerve is letter A here. And you can remember that the long thoracic nerve innervates the serratus anterior muscle. Now one good way to remember the serratus anterior muscle is innervated by the long thoracic is SALT. So that's a good mnemonic there, S-A-L-T. So S-A for serratus anterior and L-T for long thoracic. Letter B is the suprascapular nerve, which is coming off of the superior trunk, and your suprascapular nerve innervates your infraspinatus and your supraspinatus. Letter C, coming off the lateral cord, is the lateral pectoral nerve, and this is going to innervate your pectoralis major. Letter D is your upper subscapular nerve, and that one's going to innervate your subscapularis. Letter E is your thoracodorsal nerve, and that's going to innervate your latissimus dorsi. So all of these are coming off of the posterior cord here. Letter F is the lower subscapular nerve, and that's going to be innervating your teres major. So now we're moving closer to our terminal branches here. Letter G is your musculocutaneous nerve, and it innervates your biceps, your coracobrachialis, the brachialis, and the main flexors of your arm and forearm. Letter H is your axillary nerve, which innervates your deltoid and teres minor. Letter I is your radial nerve, which innervates your extensors and your triceps. If you injure your radial nerve, you're going to get a wrist drop. We'll talk a lot about that in our next lecture. Letter J is your median nerve, which innervates your pronators and your thenar muscles of the hand. All right, so next we have letter K, and this is your ulnar nerve. So this is the little baby nerve of your hand. It innervates your interosseous muscles and your hypothenar muscle, so your pinky muscle. All right, everyone, welcome to a Lewis Notes. We just got done labeling the brachial plexus, but we're going to do this again a different way. I want you to draw it out yourself, because I think if you draw it out yourself, you're going to learn it even better. So we're going to go through this together. We're going to go slowly, because the more times we go through this, you're going to get it. And then we're going to label it again in an end-of-session quiz at the end. So let's go through this together. I want you to set up your piece of paper, put at the top roots, trunks, divisions, cords, branches. Randy Travis drinks cold or Coors beer. Sometimes the branches are referred to as the terminal branches, but we're just going to use branches here. And then on the left side, we have C5, C6, C7, C8, and T1. All right, so starting with the roots, I want you to make a triangle right here, and then on C7, it's just a straight line, and then on C8, T1, we do another little triangle-looking thing here. Now, the hardest thing about the roots is that there's this weird nerve that's going to come off right here. It's going to get multiple innervations here. And what's going to be that one that goes right there? Do you guys remember that one? Remember, that's going to be your long thoracic nerve. So you're going to take long thoracic and you're going to put that one right there. So let's go back to our drawing now. So if we go back to our drawing, we're going to go to our trunks area. So if we go to our trunks, we go across there, we go across there, we go across there. There's not a whole lot to remember on the trunks. There is one on this top one right here. Do you guys remember which one that was? That was the suprascapular. So I want you to write in suprascapular right up here. Moving along, divisions. Thank goodness we don't have to know anything about divisions. You just keep on rolling right through there until we get to our cords. Now our cords is a whole different scenario. We got a lot of cords that we have to remember here. So let's go through here like this. Let's go like here like this. So in our cords at the top here, we've got one up there. Which one is that going to be? That's going to be our lateral pectoral. So let's grab our lateral pectoral and let's put that right up there. Now our middle one is going to be our most difficult cord section. We've got 3 over here, so you're going to have 1 there, you're going to have 1 here, you're going to have 1 here. What are going to be the ones that we connect here? So remember, the first one is the upper subscapular. So the upper subscapular is going to go over here. The next one is the thoracodorsal. So the thoracodorsal is going to be the middle one right there. And then the third one is going to be the lower subscapular. So the lower subscapular is going to go down right there. We don't have a whole lot of room there, but we'll just kind of sneak it in. On the bottom section, there's nothing to remember. Now, the next section that we're going to do is our branches. So the branches get a little complicated as well. You're going to have a little break right there, and then you're going to have it go all the way down, and then you're also going to have sort of this V connection right here, and you're going to get another nerve right there. So let's put all these things in. So in this little V right here, we have our axillary nerve. On the bottom part of that, we have our radial nerve that's going to go right there. On our top, at the very end here in our terminal branch, we have the musculocutaneous nerve. In the middle here, it's easy to remember because it's the median nerve that's going to go right there. And then our bottom, the ultimate nerve, the ulnar nerve, is going to be the one that goes in right there. So if you can write this out yourself maybe a couple of times, I think it will stick in your brain. And then we'll actually do this again in our end of session quiz. And now for our second review of the material. We're going to add in some detail to the anatomy, and we're going to start to learn the muscles and their functions. Again, don't panic if you don't get it all now. We'll cover this again in the next video, and we'll cover the pathology there as well. So the first one here is the long thoracic. So this is going to innervate the serratus anterior. Remember the mnemonic SALT. Now the serratus anterior is a muscle that originates on ribs 1 through 8, and then inserts at the medial border of the scapula. So the muscle's just below the armpits. It holds the scapula onto the thorax. Next, we have the suprascapular, and this is going to innervate the infraspinatus and the supraspinatus. Now, these are parts of the rotator cuff. Now, the infraspinatus externally rotates the humerus and stabilizes the shoulder joint. The supraspinatus is going to act to abduct the arm. Next, we have the lateral pectoral nerve. So this is going to innervate the pectoralis major. So it makes up the bulk of the chest muscles. Now it has several actions, including flexion, adduction, and medial rotation of the humerus, and it acts to keep the arm attached to the trunk. Next, we have the upper subscapular, innervating the subscapularis. So this is a triangle-shaped muscle that fills the subscapular fossa. It inserts into the lesser tubercle of the humerus and the front of the capsule of the shoulder joint. The subscapularis acts to internally rotate the arm. Next, we have the thoracodorsal. It's going to innervate the latissimus dorsi. Now, the lats are responsible for extension, adduction, transverse extension, and flexion from an extended position, and then internal rotation of the shoulder joint. So that's a mouthful. So how are you going to remember all that? Sometimes look at the weightlifters and see what exercises they do to work out a certain muscle. That gives me a better idea of what that muscle does. So to work out the latissimus dorsi, you can do pull-ups, or even better, lean over and pull up a bar or a dumbbell. Next, we have the lower subscapular nerve. This is going to innervate the teres major. So it originates on the dorsal surface of the inferior angle of the scapula and then inserts on the medial lip of the intertubercle sulcus of the humerus. Now this muscle medially rotates and adducts the arm. Next, we have the musculocutaneous. That's going to innervate the biceps, the coracobrachialis, and the brachialis. So these are the major flexors of the arm and forearm. Next, we have axillary nerve. That's going to take care of our deltoid and teres minor. The deltoid acts to abduct the arm, especially along the frontal plane. The teres minor acts to laterally rotate the humerus. Next, we have the radial nerve. So that's going to be your extensors and your triceps. So the triceps and the extensors act to extend the forearm, and we'll cover this in even greater detail in the next video. Next, we have the median nerve. So the pronators and the thenar muscles of the hand here. So these act to pronate the forearm. It has other functions in the hand, and we'll cover again that in the pathology in the next video. Ulnar nerve, so flexor carpi ulnaris, interosseous muscles, and your hypothenar muscle. So in the forearm, the ulnar nerve acts to flex and adduct the hand. And the hand, again, we'll cover in more detail when we go through the pathology. Okay, so that's another review of the upper extremity nerves and the muscles, and we've also labeled the brachial plexus. All right, so make sure that you can label the brachial plexus and know what muscles are innervated by those nerves of the brachial plexus. And while we're talking about the brachial plexus, I want to talk about one specific lesion of the brachial plexus, which is an injury to the superior trunk, or injury to C5 and C6 nerve roots, which gives rise to that superior trunk. If you injure that area, that causes Erb-Duchenne palsy, or waiter's tip syndrome. And so what causes this? Well, you can injure that area by trauma. The shoulder or neck can be traumatized, leading to the violent stretch to those nerves of the superior trunk. Now, the most common scenario is seen with dystocia during newborn delivery. The infant's head and neck are pulled towards the side at the same time as the shoulders pass through the birth canal. It can also occur with excessive pulling on those shoulders during a cephalic delivery as well. Now, you can also see Erb-Duchenne palsy in newborns with clavicle fractures, even if it's not due to a dystocia. And then again, dystocia occurs more often in large for gestation babies, so be on the lookout for that on your test. So how does this present? Well, the paralysis can be partial or complete depending on the damage. Now, sometimes we see just bruising or stretching of those nerves, but sometimes we actually see tearing of the nerves as well. Now, the most commonly affected nerve branches are the suprascapular nerve, the musculocutaneous nerve, and the axillary nerve. So with those nerves being affected, what will the patient look like? Well, there's going to be loss of sensation in the arm and atrophy of the deltoid, the biceps, and the brachialis muscles. The limb is going to hang down by the side, so you have paralysis of your abductors. It is also going to be medially rotated, so you have a paralysis of your lateral rotators. And then the forearm is going to be pronated, so you have loss of the bicep. So it looks like a waiter asking for a tip, kind of behind his back in maybe kind of a subtle way, asking for money. Now, usually these infants will regain full function if there's only bruising or stretching of nerves, and this is especially during dystocia is what I'm talking about here. If there's complete tearing, then sometimes the symptoms are going to be permanent. Now let's move on to Klumpke's palsy. So another portion of the brachial plexus that can be injured is the inferior trunk, so the other side of our brachial plexus, so that's C8 and T1. And what happens if you injure the inferior trunk? So you get this Klumpke's palsy. So what causes that? Well, you can have a cervical rib that can compress not only this inferior trunk of the brachial plexus, but it will also compress the subclavian artery. And this is going to cause something called thoracic outlet syndrome. And so what would you have here? So you'd have atrophy of the thenar and the hypothenar eminences, atrophy of the interosseous muscles. So what nerve are we talking about? We're talking about the ulnar nerve here. That's what's being involved. Sensory defects on the medial side of the forearm and hand, and disappearance of the radial pulse on moving the head toward the ipsilateral side. So that would be because of the subclavian artery problem. Another scenario that would cause compression to the inferior trunk is hypertrophy of the anterior scalene muscles. So that's one to know as well. Hypertrophy of the anterior scalene muscles can also lead to that thoracic outlet syndrome. All right, so that's it for our first part here. It's time for that end of session quiz. Okay, so let's go through the answers. First one here, we're doing another labeling of the brachial plexus. Very important, high yield, so let's do it again. First one, we have letter A. Which one is that? That's going to be the long thoracic nerve. B is the suprascapular nerve. C, coming off the lateral cord, is the lateral pectoral nerve. D is your upper subscapular nerve. E is your thoracodorsal nerve. F is the lower subscapular nerve. G is your musculocutaneous nerve. H is your axillary nerve. I is your radial nerve. J is your median nerve. And then K is the ulnar nerve. Be sure you know those. Next question. What are the symptoms of a lesion to the C5 and C6 nerve roots? So that's going to be that superior side. This would be Erb-Duchenne palsy again, which would show symptoms of paralysis of the upper extremity, including paralysis of the lateral rotators, the biceps, and the abductors. So the presentation is that arm hanging limp at the side with a medial rotation and forearm pronated. So the buzzword again is waiter's tip. Next, what are the symptoms of a lesion to the inferior trunk of the brachial plexus? So this is a compression of the inferior trunk of the brachial plexus by a cervical rib. So that's going to be Klumpke's palsy. So related symptoms will be sensory deficits to the forearm and hand on the medial side, atrophy of the thenar, hypothenar, and interosseous muscles. That ulnar nerve is being affected there. All right, guys, so that brings us to the end of session quiz. We do have one rapid-fire fact. Newborn with arm paralysis following a difficult labor. Remember that dystocia, always think of Erb-Duchenne palsy. All right, guys, that brings us to the end of our Neuro 19 lecture. I hope you learned something. I'll see you next time.
Well, Dr. Pemsky. It's too bad you went to med school instead of veterinary school, because these puppies are sick. What nerve innervates the biceps muscle? The musculocutaneous nerve. What nerve innervates the triceps? The radial nerve. How about the interosseous muscles of the hands? The ulnar nerve.
Well, hello there. I hope you brought your tickets to the gun show. Boo, 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 boo.